Hello and welcome to our session. My name is Charles Holmes. I'm the director for the Georgetown Center for Innovation and Global Health, and I'm joined today by Chimwemwe Mablekisi, who is co-chairing this session from the Malawi National AIDS Commission. The title of the session is Optimizing the Delivery of HIV Prevention Services for Maximum Impact and Sustainability, and we'll be focusing on the Blantyre Prevention Strategy today. As many of you know, HIV prevention is behind in meeting its goals. There are 3 times the number of new infections every year than had been anticipated at this point in the response. And there's an urgent need for greater innovation and to look for ways to sustain the response, particularly in light of the COVID crisis. So we're really happy to bring to you today a series of presentations about the Blantyre Prevention Strategy, and Sara Allinder will lead us off in that discussion. She'll be followed by Yohane Kamgwira from the National AIDS Commission in Malawi, who will talk about utilizing the HIV prevention cascade for a cohesive prevention program. Chimwemwe Mablekisi will go into the use of the cascade in subpopulations, and she'll be followed by Jeff Eaton from Imperial College, who's working with the government on modeling and district level estimates. Jeff will be followed by Dr. Kudakwashe from the Blantyre District Health Office, who will speak about the role of IDSR and community health workers in the HIV prevention response. Tyler Smith from Cooper Smith will go into optimizing data use, and in particular, the use of multi-sectoral data to drive better HIV prevention programming. He'll be followed by Kudakwashe Murombedzi, who will speak about generating demand at the community level for HIV prevention. And then Bruce Agins, who will speak about the use of QI in HIV prevention. Maureen Luba from AVAC and Compass will speak about hopes and expectations for the novel HIV prevention technologies that we know are coming, and they have the opportunity, they have the potential to really transform and improve HIV prevention, but we need strong systems around them, and Maureen will speak to that. Chimwemwe Mablekisi will close us out today, and with that, I will turn things to my colleague Sara Allinder to kick off the presentations. Thank you so much for joining us, and we look forward to the discussion.
Hello, my name is Sara Allinder. I'm Program Director for the Blantyre Prevention Strategy at the Georgetown University Center for Innovation and Global Health. Georgetown launched the Blantyre Prevention Strategy in partnership with the government of Malawi and the Bill and Melinda Gates Foundation in May 2020. Over the course of 5 years, the Blantyre Prevention Strategy aims to catalyze an innovative and data-driven HIV prevention system in Blantyre, Malawi's commercial capital. You will hear shortly from my colleague Yohane Kamgwira about BPS's systems approach to improving and boosting capabilities along the prevention cascade in Blantyre. Leadership for the Blantyre Prevention Strategy comes directly from the government of Malawi, namely the National AIDS Commission, Ministry of Health, and Ministry of Local Government, with technical support and assistance being provided by a consortium of expert partners. Why BPS? We know from the latest UNAIDS data that we are not doing as well as we would collectively like on HIV prevention. BPS represents a new approach to disrupt the trends of continuing high numbers of infection and address persistent issues in Blantyre's HIV system. The Blantyre Prevention Strategy is intentionally designed to be a break from business as usual. As opposed to traditional development and global health programs, BPS builds capacity towards sustainability and planned transition of activities from the start. The consortium of partners collaborate frequently in support of the government to share, learn, and adapt our efforts as opposed to working in silos. BPS will not provide direct service delivery, but its systems approach will provide support to service delivery being provided by other partners such as PEPFAR and the Global Fund. And it will strengthen the foundation of the overall HIV prevention response. Finally, the strategy and the work plan is iterative. we will not have a fixed approach starting from this initial period in year one. We will make changes and adjust as lessons learned are learned, both positive and negative, over the course of the 5-year period. Core to that is our learning agenda and implementing activities that seek to answer 3 core questions. These are: what are the core elements required to underpin a local HIV prevention response at the district level within an optimized system? 2, can those core elements be institutionalized within the existing government framework and institutional structures? And 3, can we effectively introduce new biomedical prevention products into the strengthened system? Our hope is that by working toward answering these questions and the answers they yield, we will catalyze that data-driven HIV prevention delivery system in Blantyre and enable expansion of the approach elsewhere in Malawi and to other countries around the world. In addition, we expect the system's approach will enable improved access, quality service delivery, and uptake of existing HIV prevention services and tools, and pave a smoother path for introduction of new HIV prevention technologies as they come online. Yohane will tell you more about how this approach will improve those targeting, demand generation, service delivery, and sustained use capabilities along the prevention cascade. Thank you.
My name is Yohane Kamgwira. I work for National AIDS Commission as a coordinator for Blantyre Prevention Strategy, and I'll be making a presentation on utilizing the prevention cascade as an organizing principle for cohesive prevention program. As we are aware, HIV prevention, business as usual, is no longer working. And this has been demonstrated by the latest data from UNAIDS, which indicates that as 2019, prevention continues to be the critical weakness in the overall HIV response and the barrier towards achieving the 2030 goal of ending HIV as a public health threat. New HIV infections have remained stagnant worldwide for a decade now. And as of 2019, there were 1.7 million new HIV infections globally, which is over 3 times than the target of less than 500,000 a year by the end of 2020. Blantyre as a district is making commendable efforts towards attaining the 1990 targets, but continues to have high rates of new HIV infections. There are persistent reservoirs of infection which threaten long-term epidemic control, despite existing effective prevention interventions. And this calls for a more robust approach to disrupt HIV transmission, support those at risk, address structural barriers and infection drivers, and institutionalize high-quality or targeted sustainable HIV prevention services. Blantyre Prevention Strategy is therefore a new approach that addresses ongoing challenges to HIV prevention services in Blantyre, with a goal to drive down new HIV infection. The Blantyre Prevention Strategy will attempt to address existing challenges in the prevention delivery systems, which are characterized by poor risk assessment, weak data systems, short-term program focus, inconsistent community demand, which leads to fragmented prevention delivery. And the HIV prevention cascade is advancing that HIV prevention and achieving targets requires identifying the target population and direct mechanisms of prevention, increasing coverage of these mechanisms through demand-side intervention that foster appropriate risk perception and improve awareness and acceptability of the direct mechanism of prevention, as well as supply-side intervention that make prevention products and procedures more accessible and available. And lastly, adherence interventions that seek to close the gap between behavior intervention and action by supporting ongoing adoption and use of prevention behaviors. The project has got 2 desired outcomes, which are development of a district-based system that will enhance employment and uptake of HIV prevention interventions, and ensuring HIV prevention is institutionalized as a cohesive, effective, and sustainable country-led response with coordinated external support. As an overview, the project is responding to the problem of persistent reservoirs of infection, which threaten long-term epidemic control, despite the existence of effective prevention interventions and emerging novel prevention products. The project will therefore make investments along the HIV prevention cascade and in the 6 key enablers in order to reach out the stated outcomes. The 4 prevention cascades include targeting high-risk populations, generating demand for prevention services, delivering prevention services, and enabling effective and sustained use of prevention services along the 6 key enablers of governance, technical leadership, sector partnership, civil society engagement, community engagement, and data system, which we feel will lead to establishment of a district-based system that will enhance deployment and uptake of novel and existing HIV prevention interventions that will institutionalize and embed it within local systems and capabilities. The project therefore aims to strengthen district-level capabilities along the 4 HIV prevention cascade. For example, in the under targeting, the project intends to attain the capability to estimate and detect HIV incident infection and populations most at risk of HIV acquisition, the capability to determine the right intervention mix and delivery channels for reaching the identified at-risk populations, and the capability to direct resources and services to the identified populations in a rapid, effective, and sustained fashion. Under demand, the capability to develop data-driven, community-informed, responsive, and adaptive prevention programs that are attractive to at-risk population, and the capability to generate demand for these programs through routine and sustainably financed public health messaging campaigns, and a strength and engaged civil society organization and CBO network. Under delivery, the capability to deliver quality HIV prevention services through coordinated public and private delivery channels at the community and facility level to populations most at risk of HIV acquisition, and the capability to measure program performance, quality, effectiveness of prevention programs in reducing incidents to adapt and expand user-provider interfaces as needed. And under sustained use, the capability to identify and address community level, facility level, and structural barriers that interrupt sustained and effective use of prevention tools by users during periods of risk. And in the key prevention enablers, which are the building blocks for the capabilities, we are, as already indicated, we are looking at governance, where I want to ensure this level governance and the oversight structures that can facilitate strong coordination with HIV prevention, and under technical leadership, building capacity within the government system at community and the facility levels. Data systems want strengthened data infrastructure and the ecosystem. And then under civil society capacity, we want networked civil society organizations and the CBOs that are able to fulfill their mandate in service delivery, community mobilization, monitoring, oversight, and advocacy. And community engagement want to engage to ensure that there is engagement with a wide range of communities, from the key populations, the youth, community leaders, and the community members themselves. And under multi-sectoral partnership, we want engagement with the private entities to ensure that they're able to provide the financial and technical support toward this HIV prevention. And as an example, of BPS health system investments under governance. We have integrated disease surveillance and response towards HIV as a pilot, data use study, technical leadership, we conduct special studies, monitor HIV incidence trends, capacity building of district health office and the city health office, network mapping of service providers and the data systems, development of preventive adaptive learning and management system and data pipeline under community engagement and civil society, human-centered promotion of human-centered design approach, and prototype collaborative under multi-sector partnership, investment in the communities of practice, and establishing Health Aid Communications Council. Thank you for listening.
I don't know whether I should say good morning or good afternoon, but hello everyone. I am Chimwemwe Mablekisi. I'm the Director of HIV and AIDS programs in the National AIDS Commission, Malawi. The National AIDS Commission is responsible for coordinating implementation of the Blantyre Prevention Strategy project on behalf of Malawi government. I'm going to share with you a presentation on how Prevention Cascade is being utilized for different population groups, in particular key populations and adolescent girls and young women. I will therefore now start sharing my screen. Since the focus is on Blantyre district, I will give you a brief HIV profile for Blantyre, then the new HIV infections in Malawi, and then zero in into the prevention cascade for KP and adolescent girls and young women. The 2016 MFIA estimated HIV prevalence in Blantyre and the Malawi as a whole for 15 to 64-year-olds. For Blantyre, it was estimated to be 17.7%, which was much, much higher than the national average at 10.6%. Blantyre district is in the southwest zone, and you can see that the southwest zone prevalence is even lower than Blantyre. This called for deliberate attention to HIV prevention efforts in Blantyre to reduce the prevalence and new infections. Hence the several efforts that the government, with support from different partners, have embarked on in Blantyre, and this includes the Blantyre Prevention Strategy. The second MFIA is currently in progress, and the results hopefully will determine the gains that we have achieved in the acceleration efforts that we have been doing in Blantyre since 2016. Since the first AIDS case was detected in Malawi in 1985, we've seen new infections increasing with a peak around 1990s. With the various HIV prevention efforts, we've seen the trend in new infections declining. Through the UN's fast track targets of the 1990, we had also set ourselves a target of reducing new HIV infections by 75% to achieve 11,000 new infections as at the end of 2020. But as you can see from the graph, as at the end of 2019, we're at around 33,000 new infections, already indicating that we are off target from our from the target that we set. Of course, we missed the target, but we can still see some reductions in new infections. Like in 2019, in adults above 15, we had registered a 27% reduction. And then in adolescent girls and young women 15 to 24, we had registered about 22%. This calls for a scale up in integrated HIV program. The Blantyre Prevention, HIV Prevention Cascade focuses on 4 outcomes, that is targeting, demand generation, effective delivery of HIV prevention interventions, and also ensuring that there is sustained use of the innovations that will come from the various efforts. So for key populations, in Malawi, we are mainly focusing on female sex workers, men who have sex with men, MSM, as well as transgender. We do not yet have data on people who inject drugs, but currently a study is going on so that we can estimate the size of people who inject drugs and so that we can effectively design interventions for that group. The 2013 biological and behavioral surveillance survey estimated prevalence in female sex workers at 62.5% and in MSM at 18%. And already these are higher than the national average. In order not to leave anyone behind in the HIV response, government made a deliberate effort to focus on key populations. So for key populations, the first and foremost is to identify them, find out where are they, which are the hot spots that they are found. Once we identify them, then we reach out to them with prevention services. And the initial service is the testing. There's continuous engagement with HIV negative as well as positive KPs on combination prevention. Combination prevention includes access to condoms, lubricants, psychosocial support, and then we ensure that HIV negative KPs access regular STI screening and treatment, also regular HIV testing on a quarterly basis, but also the offered PrEP. For those who are positive, following the 90-90-90 treatment targets, we ensure that we diagnose 90% of the KP, and the 90% of those diagnosed should be initiated on treatment as well as retained into treatment so that we achieve 90% viral load suppression. So what are the core package of services that we offer to our key population? The prevention cascade mainly focuses on reaching, testing, and offering prevention interventions. So we focus on peer education, risk assessment and counseling, condom and lubricant use, HIV testing and counseling. For female sex workers, we also provide family planning. As I mentioned earlier on, also provision of STI screening and treatment. Last but not least, also provision of PrEP services. Adolescent girls and young women is another group that government of Malawi is focusing on because of their vulnerability to HIV infections. Adolescent girls and young women compose 10% of the population, but 25% of new infections are occurring in this subpopulation, basically because they've got limited access to sexual and reproductive health services as well as HIV services, which are principally offered through health facilities by healthcare workers, and most of them lack youth-friendly skills, but also with limited youth-friendly health services outlets. The Global Fund Office of the Inspector General recommended that we need to have a specific package for adolescent girls and young women. Yes, government of Malawi has developed a minimum package of HIV prevention interventions for adolescent girls and young women, and also has designed modalities on how these interventions will be delivered. So we have a core package for different age groups, both in and out of school. And based on HIV safe risk and vulnerability assessment, these are also linked and referred to additional layer of services. On targeting, as I said, the package targets both in and out of school youth of different age groups. They are offered HIV risk assessment, and this will determine access to layered interventions. And those who are determined to be most at risk are referred and linked to additional services on top of the core package. To ensure that demand is effectively generated, we have engaged communities. The communities have been mobilized, including parents. Then they are offered the norms change program, but also peers are involved so that they effectively reach out to their fellow peers and to bring them to access HIV prevention services. Delivery of the core package and all the additional layers based on the risk assessment that is done is through integrated youth-friendly health services, as well as outreach services. We also promote peer-led community-based service provision, both for HIV prevention as well as sexual and reproductive health. We support development and establishment of teen club, as well as community youth centers, as well as treatment literacy centers for those youth that will be found positive. Monitoring will be a continuous process to ensure that the services or the delivery models are really bringing the impact that we're looking for. We want these interventions to continue being delivered both at community as well as facility level. So the communities that will be mobilized, the peers that will be involved, those will ensure continuous provision of the services. That's the end of my presentation. Thank you very much for your listening. Thank you.
Hi, my name is Jeff Eaton. I'm a senior lecturer in HIV epidemiology in the MRC Center for Global Infectious Disease Analysis at Imperial College London. And today I'm going to talk about work that we've been doing with colleagues in Malawi on developing district-level HIV estimates for a more effective HIV response. As many of us will be familiar, in recent years there's been an increased focus on HIV programs, targets, and resource allocation at the district level. Annual targets for HIV testing and treatment are based on district-level estimates of unmet need, and achievement of those targets are increasingly interpreted as metrics of local HIV program effectiveness and accountability. Using these data for target setting requires timely and accurate strategic information about the current status of the epidemic at the district level and by fine, age, and sex disaggregations. But the challenge that we face in producing these data are that the data available from which to quantify the HIV epidemic at the district level is much sparser compared to the data that are typically available at the provincial or national level. So over the past 3 years, we've worked with colleagues in Malawi, in particular the Department of HIV/AIDS and the CDC in Malawi, to develop new mathematical modeling approaches to produce the required estimates at the district level. The approach that we've developed, which has now become the NAOMI model, is to synthesize and triangulate all available sources of data at the district level, including data about population size, data from household surveys, such as the MFIA survey, the Malawi Population HIV Impact Assessment Survey, and the Malawi Demographic and Health Survey about HIV prevalence, ART coverage, and the proportion of people living with HIV who were recently infected. ART program data about the number receiving antiretroviral treatment at each health facility in each district, and antenatal clinic testing, HIV testing data, which provides information about HIV prevalence amongst pregnant women attending antenatal care in each district, as well as data about antiretroviral treatment coverage prior to the first antenatal clinic visit for a given pregnancy. These ANC data are key data providing information about spatial variation in HIV prevalence and ART coverage at the population level. The outputs of the model are robust district-level estimates for multiple outcomes of interest, including HIV prevalence and the number of people living with HIV in each district, the antiretroviral treatment coverage and the unmet need for treatment, and estimates for the number of new HIV infections in each district. All of these results are stratified by sex and 5-year age group, and results are produced with statistical uncertainty ranges for each quantity in each district. And here's a summary of some of the results that come from the model. For example, here are estimates for the HIV prevalence and the number of people living with HIV in each district of Malawi, produced for the official national HIV estimates at the end of 2019. As we're, I think, generally familiar, the estimates reproduce higher HIV prevalence in the districts in southern Malawi, including Blantyre City and Zomba City, but we also see a large overall number of people living with HIV in the districts, for example, of Lilongwe City, where there's a moderate HIV prevalence, but a very large population size. Similarly, we can get estimates of the ART coverage in each district, as well as the number of residents in each district who are on treatment. We can see that overall, ART coverage is somewhat more homogeneous across districts, kind of between 75 and 85% in most districts at the end of 2019. And then finally, we obtain estimates of the HIV incidence rate and the number of new HIV infections occurring in each district. And as noted, for each of these estimates, we're able to produce or obtain estimates of the statistical uncertainty. And so this plot here shows for each district the estimate as well as the posterior density of plausible values for each indicator. And as we can see for HIV prevalence, the results clearly reflect the large heterogeneity in HIV prevalence, from lower prevalence in the northern districts to higher prevalence in the southern districts. For ART coverage, the coverage is generally much more similar across all districts. Whereas if we look at the HIV incidence and the number of new infections, we generally have more uncertainty around current estimates for incidence and new infections. These estimates have been very successfully and widely used for HIV policy and planning in Malawi, for example, incorporated into the recent 2020 to 2025 revision of the Malawi National Strategic Plan for HIV and AIDS. However, as we noted on the previous slide, there's relatively large uncertainty around our quantification of HIV incidence and the number of new HIV infections at the district level. So a large portion of our work going forward as part of the Blantyre Prevention Strategy is to develop new modeling approaches and use new data sources to improve our estimates of new HIV infections at the district level and identify those populations in which new infections are occurring and would benefit from increased HIV prevention. So one stream of this work are to develop more robust estimates of district-level HIV incidence trends. And in this work, we're combining multiple longitudinal data sources to estimate trends in HIV incidence and the HIV transmission rate within each district. So this involves looking at the full time series of household survey and quarterly reported HIV program data, and then using quarterly program data, each quarter as new data are available, using those to update our inference about HIV incidence trends in real time. A second theme of our work is to identify priority populations for HIV prevention. For this, we've conducted a literature review of HIV risk score literature, and the results of this review have been quite interesting. Firstly, two of the key risk factors for HIV incidence are already the key factors that we include in all of our modeling. These include persons who reside in a location with high untreated HIV prevalence or higher risk of infection, underpinning the focus on district level strategy and district level targeting of prevention interventions, and also in particular women at younger age, women in the age range 15 to 24 have an increased risk of HIV incidence. The literature has also suggested a couple of other factors that aren't currently accounted for in our modeling of HIV risk and transmission. These include women who are sexually active and not married, for example, formerly married women or never married women, and women who have had a recent sexually transmitted infection. And so the next steps for this work are to synthesize this information about risk factors, estimate the sizes of population at risk according to these risk factors by district and age, and then define an overall infection risk and prevention need based on both the community level risk based on the prevalence of untreated infection in each district and the individual risk characteristics that have been identified through the literature. And then lastly, we would like to incorporate into our modeling the coverage and impact of HIV prevention interventions. There's two steps here. Firstly, are to identify key HIV prevention intervention strategies and estimate the coverage of those prevention interventions at the district level, and then to reflect the intervention impact on new HIV infections in our model-based estimates of incidence. As an example here is preliminary work on estimating medical male circumcision coverage at the district level in Malawi. For example, in the figure, we've developed a model to estimate the rate of male circumcision by age and whether circumcision was a traditional circumcision or a medical male circumcision. And this model is used to triangulate VMMC program data along with household survey data about male circumcision and produce estimates of coverage and unmet need by age and district. And in the next step for this modeling, we'll be incorporating this information into our estimates and projections for HIV incidence in each district. So to summarize, the Malawi HIV program have pioneered novel approaches to triangulate district HIV burden and treatment coverage. And similar methodology to what's been developed with our colleagues in Malawi has now been applied by many countries across sub-Saharan Africa, supported by UNAIDS. These granular data that come from these modeling exercises support effective planning, implementation, and evaluation of HIV testing and treatment programs. And going forward, we see the next steps for this modeling to have a renewed focus on prevention of new HIV infections, including granular real-time inference about new HIV infections from data on HIV testing and treatment, quantifying populations at high risk of HIV by community and individual level characteristics, and quantifying the coverage and impact of HIV prevention interventions. Thanks very much for the opportunity to speak today.
Good morning or good afternoon. First of all, let me thank the organizers of this important conference. I'd also like to thank our colleagues at the Malawi National AIDS Commission and Georgetown University for organizing this panel. I'm Tyler Smith, the co-founder and chief technical officer for Cooper Smith. We've had the great fortune of working hand in hand with HIV providers, policymakers, and funders in Malawi for several years now, and we're really excited to be the lead data partner for the Blantyre Prevention Strategy. By now, hopefully you have a better sense of how the strategy intends to be different from past prevention efforts. This lens on innovation very much extends to our data approach as well, And so today I'll walk you through our plans to develop a multi-sectoral data pipeline that we hope will not only optimize data use, but also prevention services in the district. As we were gearing up for this engagement over the past year plus, we really took stock of all the information that is at our disposal to inform HIV prevention programming, both in the district and at the national level. We found these data to be lacking. Traditional data sources do little to help us evolve our understanding of HIV acquisition risk or prevention performance writ large. And we really argue we need a new paradigm for thinking about which information is most relevant and most useful for targeting services and driving down incidence. And there's a couple of primary reasons why we think we need this new paradigm. The first is that the lens we typically have is too narrow. So when you think about it, the people that we are trying to identify and provide support to have incredibly complex lives, and only a small fraction of their time is spent engaging with the formal health sector. When we do have a touch point with them, their experience is usually reduced only down to a few data points, things like age, sex, home location, if we're lucky, diagnostic result, and treatment. And we know that social determinants of health, such as socioeconomic status, education, food security, account for as much as half of health outcomes. And certainly these will play a role in HIV acquisition. I think we do a fairly good job of thinking about designing prevention programs so that we incorporate these other facets and more pervasive facets of individuals' lived experience, but we don't do a really good job of understanding data that comes from other sectors that would help us to better potentially predict new infections or respond really quickly when situational factors might influence upticks in incidence. So I see this as a major missed opportunity given the wealth of data that's already existing in a country like Malawi. The second reason we need a new paradigm is that the systems and processes that we have for data use now are overly fragmented. And I know that anyone who works with HIV data will commiserate with me on this point, but I've tried to illustrate some of the complexity of the data ecosystem at country level in this diagram. From the point of origination, point of care for information, to the user or actor who intends to take that information and do something with it, there's multiple steps and processes and functions that must happen in a country like Malawi. And this includes collection on paper-based forms, digitization of that information. There's usually some sort of transformation process. Obviously, it must be stored somewhere. There's manipulation or analytics that need to take place on those data. There's various ways the data can be accessed by users, and then there's tools that allow you to visualize and report this information. And so when you think about any one particular use case that you're interested in, so generating an insight for an actor who is trying to make a decision or take an action, you might end up with an information pathway that looks something like this. So data come from multiple different sources. They're transformed in different ways. They're stored in different places. They're manipulated in different ways and accessed through different points. Similarly, for another use case, you might see an equally convoluted pathway, but slightly different in the tools and processes that those data must go through in order to be useful. And then we can continue to draw lines here for yet another use case. And I think the important thing to keep in mind is that many of these steps, these components of the data ecosystem are similar. And so there's a lot of opportunity for us to rationalize this process and create quicker, more efficient data pools that really respond to users' needs much more appropriately. So how are we planning to streamline these processes into an optimized HIV prevention data pipeline? I think the first thing is that we're not going to get tripped up in the complexity of the country ecosystem and take a supply side approach to trying to streamline and rationalize. We've really flipped the model around to focus on the user first. So all of the software, the data support that's provided through BPS will be user driven, meaning that every activity that we undertake must be linked to a country developed use case and in service of that use case. Here's an example of what we mean by use case. There are 2 user stories we've included here. Through the formative work for BPS and the ongoing engagement with stakeholders at all levels, we've been able to develop this core set of use cases that are priority for HIV prevention. These include how information would be optimally used to act most effectively and at the right time. And so in the first example, the top tile, you can see that we have a Blantyre city councilor, and she's able to access information on population movement in and out of the city during rainy season. She is further able to identify venues that have been mapped for high-risk HIV behavior and compare the areas where we expect to have those population movements with the high-risk venues. The idea is she can then take this information to allocate resources or mobilize partners to mitigate that risk at the right moment in time. In the second tile below, we have an STI clinic nurse, and she's able to layer data from STI testing and diagnosis spikes with outreach activities in the community. And here we're trying to understand which mobilization activities result in the highest yield of high-risk individuals that are coming to clinic. Once we've documented all of these use cases, our goal is to allow the information to flow as efficiently as possible. And so we began to think of the streamlining efforts really as an information value chain, and trying to group those various components into key functions along this chain and figure out where we can consolidate steps, combine common processes, and return insights much faster. Obviously, prioritization will be key here and country stakeholder driven. It's also important to highlight that almost all of this incredibly complex digital architecture, analytics, and processes will be developed and maintained by Malawian nationals working as part of the Malawi Ministry of Health. We've been committed to real and measurable technical capacity development since our first day in country, and the BPS work will enable further strengthening of this digital health cadre and put the government in control of core systems and components of the data pipeline. The good news is, in terms of sustainability, we have a lot to work with in Malawi. Some time ago, Malawi adopted the Open HIE digital framework. This is really an organizing principle for a coherent enterprise architecture for digital health. All of the items within the framework are shown here in this diagram. Those highlighted in green are fully functional and operational in Malawi, with the remaining components either in development or planned. All of the additional tools, support, software, analytics will be leveraging and built upon this core underlying architecture in Malawi. And finally, I would like to talk a little bit about the comprehensive monitoring system we've put in place that we also feel is pretty novel and will be largely fed by this prevention data pipeline. We're calling it the Prevention Adaptive Learning and Management System. The idea is both the learning and metrics that we're using are adapting, as well as the management that results from them. There's 2 core functions of this, one being an internal facing side and the other an external facing side. For the internal, we're really focused on transparency and accountability for the work that we're undertaking within BPS, and ensuring that progress is happening as intended and that those elements of support are performing the way that we would hope. For the external side, it's really meant to focus more on prevention performance in the district writ large. So thinking about all of the information we have at our disposal for programmatic activities, key prevention performance metrics, modeled estimates of incidence and coverage, et cetera, and taking all of that into one comprehensive and easy to digest set of information everyone is able to look at, all the key stakeholders can take into their communities of practice or into their management meetings, and really be speaking a common data language when they're making strategic choices. Finally, there's this schematic which outlines how we envision the PALMs to work. So you can see the BPS consortium partners along the bottom here. We have our investment priorities, which are largely driven by the government. We have our BPS activities that we're undertaking, and then our progress indicators, which is that internal side to let us know that that's all happening as intended. Above, we have kind of the full set of all other HIV prevention stakeholders. They have their own investment priorities, and that translates into HIV prevention activities and services deployed. Our goal is that data taken from their activities, as well as merged with all the data from the BPS work, will come together in that external facing data set, which we're calling key prevention performance indicators. And that information would then be easily accessible by the full set of stakeholders and hopefully inform investment priorities as well as HIV prevention activities in a very iterative and frequent fashion. And finally, we are working on developing a core set of sustainability indicators that will help us to understand how likely all of these systems are to persist into the future. So thank you very much for your time. We're really excited about taking on these substantial challenges and would love to hear your thoughts or feedback. So let us know. Please take care of yourself during this unprecedented and challenging time in history. Thank you very much.
Hello, my name is Kudakwashe Murombedzi. I'm representing Population Services International, and we'll be taking you through our presentation on generating sustained demand for HIV prevention under the Blantyre Prevention Strategy in Malawi. As PSI, our mission is to make it easier for all people to lead healthier lives and plan the families that they desire. In Malawi, PSI has been operational since 1994, providing HIV, SRH, and malaria programs. Under the Blantyre Prevention Strategy, PSI has three broad roles, but this presentation will focus on role number 3, which is the creation of a grassroots human-centered design model that can be locally owned and implemented. In many years of implementing HIV prevention interventions in Malawi, we've learned that creating and sustaining demand for prevention services and products is the key challenge in reducing new infections. So many behavioral biases influence how our clients interact with the different products and services, prevention products and services that are out there in the market. Some of these biases include the salience bias, which has us focusing on things that seem more immediately scary or rewarding than what is empirically risky or valuable. The present bias, which has us value present barriers and opportunities more highly than future ones. In VMMC programming, an example of this present bias might be the way in which clients or men would rather look at the 6-week abstinence period as an immediate consequence rather than focus or internalize the long-term benefit, the long-term future benefit that VMMC or circumcision provides. There's also the hot cold empathy gap, which makes it really hard for us to predict our behaviors accurately. All of these behavioral biases combine to make it really hard for human beings to choose and to use HIV prevention consistently. In order to overcome these challenges, a strong prevention program must do more than just advertise. It must do more than just preach. We need to deeply understand the end user of the intervention. And increasingly, we must design the program with them so that we create solutions that are salient, that are attractive in the moment, and that are easy to use in the right time and place. Over the past decade, the development community has been experimenting with human or user-centered design. This is a methodology that puts end users at the center of the design process. As PSI, we've been adapting HCD for use in our health programs for the past 5 years, and we think it holds real promise for addressing these tough prevention challenges. But it needs to be adapted so that local governments and local or community organizations can unlock its promise. With its origins in the private sector, human-centered design is a collaborative and iterative process that positions end users as equal partners in the design of a product or service. When it's adapted for the health system, HCD becomes a process that puts clients and patients at the center of the design process and engages all the key constituents in the process of designing and defining the problem or question, coming up with possible solutions and testing them. So when we look at this diagram, an HCD process begins with building empathy and understanding of the end user for the product or service. This usually involves loosely structured engagements with representatives of the end user groups. And while we're equipped with this understanding, we move to defining the problem or the question. For BPS, we can imagine that time spent in this empathize phase for an intervention like PrEP might lead to an insight like young people that live with their families or their parents do not want these people to suspect that they're sexually active, and having a bottle of PrEP pills around them is a problem. For the purpose of design, this problem is reframed as a question, and the question would be, how might we make it easier for a young person living with parents to take a pill every day? We then move with this question to the ideate phase, where we generate a range of possible solutions. And this phase often takes place in a workshop setting where design experts usually use games and creative tools to unlock great ideas from these people who know best what could work. We then move to the prototype phase where the team leading this process comes up with some quick, rapid, low-fidelity versions of these ideas and test them out. So while this is the typical HCD process, and while HCD and design thinking are often associated with slick brands like Nike or like Apple, these processes are democratic at heart and they're community-based. They involve bringing together the people most involved in the intervention, and they create an environment in which everyone can offer his or her best thinking. The challenge that is there before us is therefore to create a version of this approach that can be deployed by and on behalf of the Blantyre community of practice in order for us to solve HIV prevention challenges on an ongoing basis. If we can develop an approach that works, it should be applicable across many settings in Malawi and beyond. As we embark on this journey to essentially design for design, as we develop this grassroots HCD model, we believe and strongly think that the grassroots HCD model will be ideal for addressing some of the challenges that we anticipate with the introduction of new technologies such as CAB-LA and the dapivirine ring. New biomedical interventions inevitably present both opportunities and risks to users. For CAB-LA is quite discreet, but the shot is painful, and the interval between shots doesn't neatly align with contraceptive methods like DEPO or oral contraception that is most common in Malawi. We'll need to work closely with both potential users and providers to build a delivery system that makes the shot work for both women and men. Likewise, the ring is promising, but it also has some distinct limitations. Helping women understand those limitations and figuring out how best to use the ring will also demand input from both the end user and the provider. In both cases, really, like with all HIV prevention interventions, ensuring the broader community is aware and brought in is essential to creating the enabling environment that young people need in order to adopt new technologies. A grassroots HCD model offers the chance to address these challenges and the subsequent ones destined to emerge as the government of Malawi moves these technologies from pilot to scale up. And as the context in Blantyre shifts, The truth is, there is no single model that works forever. Conditions, beliefs, and resources are constantly changing, and our models for delivering HIV prevention needs to adapt rapidly and change along with them. How will we create this grassroots HCD model? PSI, together with the district, is engaging a Nairobi-based design firm to lead a development process with the district health office and the various stakeholders. So we'll use PrEP as a model intervention, and we'll iteratively build an HCD model that can be implemented and adapted over time by local users. As we are piloting the use of this grassroots HCD model, we will use oral PrEP as a model intervention, and through this process document experiences, preferences, and insights from high-risk and underserved groups which form part of the PrEP target audience, and provide insights into their needs, their preferred delivery channels, barriers, motivators, and even their aspirations. We will prototype together with communities the appropriate community-based solutions to critical barriers that would have been identified using the grassroots HCD model. We also design clinical solutions with clinical staff in collaboration with HEALTHQUAL. The grassroots HCD model or workshops will continuously feed insights into the data pipeline, the district data pipeline, and provide real-time data to district health office and other decision makers, data that will assist, insights and data that will assist to shift programs, to shift policies and resources towards what is effective and in terms of demand and service delivery interventions. Lastly, we will document lessons learned to inform future demand generation for future prevention products such as products and services such as CAB-LA and the dapivirine ring. So that marks the end of this presentation. Thank you so much for listening in.
Thank you for the opportunity to talk to you today. And I'm going to ask and hopefully answer the question, is quality improvement the missing link to scaling up prevention services? As you've heard and seen from my colleagues, the Blantyre Prevention Strategy is designed to strengthen systems that develop, implement, and execute services along the HIV prevention cascade. The quality of these services is an essential focus, just as it is for healthcare services. And our goal across the prevention cascade, through coordinated public and private delivery channels and at community and facility levels, is to ensure that prevention services are safe, accessible and timely, effective, efficient, equitable, and person-centered. Quality services, moreover, will be informed by activities such as human-centered design and data-driven surveys to ensure that they're responsive to need, and when implemented through routine measurement and testing of changes, will lead to sustainable delivery to achieve our desired outcome of preventing HIV transmission. We'll be starting with PrEP, and I think the rationale for that is clear. PrEP is a proven intervention to prevent HIV infection. And Malawi has a PrEP target of 20,000 individuals for PrEP, but at this time only about 5% have been initiated on PrEP. There are numerous barriers to implementation and scale-up, including limited knowledge about local implementation in different contexts, limited management capacity of PrEP services, public political will to focus on key populations, resource constraints, service disruptions because of COVID, and stigma, which is a pervasive barrier to all HIV services. Currently, PrEP has been launched in Malawi with a focus on adolescent girls and young women, sex workers, men who have sex with men, and serodiscordant couples. A policy brief promoting PrEP was introduced in April of 2019. PrEP is offered currently in diverse settings, including drop-in centers, family planning, and STI clinics in both the public and private sector. And we know that key inputs are needed for successful implementation that have to be managed, including human resources, lab capabilities, commodity and supply chain management, infrastructure, and effective data systems, as well as provider capability and knowledge and patient education so that individuals who are in need of PrEP understand its benefits and use it effectively. Quality improvement is perfectly suited for addressing this kind of a complex system. What quality improvement enables us to do is take what we may know already and then focus on how to implement that and do what we call closing the no-do gap so that we can deliver services as effectively as possible. One of the fundamental principles of quality improvement is that every system is perfectly designed to achieve exactly the results that it achieves. And even though we may not have purposefully designed a system in a certain way, it's functioning as if we did design it that way, and it's going to continue to function in exactly that way in which it exists unless we change that system. And we do that through a series of methods in quality improvement that focus on the processes that make up those systems. We continuously measure what we're doing to reduce variation in performance and improve it. We involve teams of providers and patients and agencies to identify barriers and then solutions to address those barriers in their local settings. Focus primarily on the needs of clients. We test and measure those effects of change to know whether or not they're working or whether we need to tweak them between one setting and another or stop doing them because they don't work. And then we capitalize on the knowledge gained in one setting and exchange that knowledge with people applying it in another setting so we can spread those ideas more quickly. We'll be using a specific methodology of quality improvement called a collaborative. And the collaborative is a methodology that brings together groups of practitioners from different organizations. We'll be including public health professionals and the community to work in a structured way to improve one aspect of the service delivery system, in this case, PrEP. And it will involve a series of meetings to learn about best practices and using quality methods to improve the system. Here's a schematic that shows a collaborative divided into three phases: a planning phase, implementation phase, and then a scale-up phase. And in the planning phase is where we develop the goals, a set of measures that we'll be using to measure performance. The participating agencies bring their teams together, and everybody gets ready so they can hit the ground running for the actual implementation, which consists of learning sessions where the teams from the different agencies come together with those of us who are leading the collaborative, in this case, My Conduct Trust, and some of us from HEALTHQUAL. And then in between those learning sessions, they are conducting those tests of change on a frequent basis so they can learn what's working and measure it and come back at the learning sessions and share their experiences with each other. And in this way, really accelerate the pace of improvement by spreading these ideas much more quickly, so that by the end of the third learning session, we can compile those interventions into a package that can be used for effective scale-up and dissemination beyond the sites that are participating in the collaborative. Circling back to the Blantyre Prevention Strategy, we can now overlay the PrEP Collaborative to show how we'll use this methodology to target high-risk populations by focusing on adolescent girls and young women, sex workers, and men who have sex with men. Generating demand for services by directly involving the community in all aspects of the initiative. Building on the integrated data pipeline, and using these methods of measurement and testing changes to learn how to deliver the most effective services. And throughout, we'll be adhering to the principles of BPS by building and strengthening capacity in the district. They will be leading the initiative, and the idea will be to strengthen their knowledge and capacity for the ongoing leading and management of quality initiatives that can extend beyond PrEP and into other services. Further elaboration shows how specific activities such as human-centered design and the collaborative planning process will involve the community, how its implementation will involve the mix of service types delivering PrEP in the public and private sectors, including those that focus on specific key populations. And our evaluation will be measured by analytics of structures, processes, and outcomes. Before I close, I'd like to focus briefly on the specifics of improving PrEP within this complex adaptive system, as we've described. And because it would be too easy if all we were to think about was prescribing pills, teaching providers about the medications, or how to give injections. But rather, the processes involved are numerous, and many are challenging, and they are all ripe for application of quality improvement to facilitate their implementation. So domains of effective service delivery would include appropriate clinical management, including HIV and STI testing, monitoring for drug toxicity, reducing stigma with emphasis on private and confidential services and making agencies welcoming, offering comprehensive services, including especially mental health services, and providing PrEP as part of the continuum of combination HIV prevention services. Other changes will include having regular data collection through tracking systems to monitor PrEP indicators routinely, preparing the entire staff to understand how to deliver effective services to key populations, and empowering clients to participate most effectively, as well as accessing community services and agencies to facilitate delivery of services and supporting clients. There are unique challenges to applying PrEP, QI to PrEP. And this includes the identification of the eligible population for measuring access, the denominator. How will we know how many adolescent girls, young women, sex workers, men who have sex with men in the community should be accessing PrEP? How do they perceive their risk for transmission, and how can we affect that and measure that? How do we measure demand creation? How can we link internalized and community stigma with access to PrEP? And how many people are eligible related to a specific site where PrEP is being given, and what's their agency denominator? And finally, what kind of measurement can be performed connecting the work in the community to the service delivery organizations? And these are all things that we'll be addressing as we build the collaborative in order to achieve our ultimate goal, which is the sustainability of services over time. And specifically, we want to be able to prepare the service delivery channels for the rollout of long-acting PrEP when it's available, identify best practices for development of change packages to facilitate this dissemination and scale up, build communities of practice for ongoing peer learning, strengthen human resource capacity in the district for quality management, quality improvement coaching, and for leading collaboratives, developing long-term sound public health policy and coordination of high-quality service prevention systems. Just a quick shout out to all of our collaborators in this project, and I want to thank you much for your time and attention.
Good morning and good afternoon. My name is Maureen Luba. I work for AVAC as the Africa Region Advocacy Advisor. From the previous speakers, you've heard about the Blantyre Prevention Strategy Project. You've also heard about the HIV prevention landscape in Malawi, as well as the challenges and opportunities that are there for preventing new HIV infections. And my presentation will focus on what hopes and expectations do new HIV prevention technologies offer as far as reducing the number of new HIV infections is concerned in Malawi. Of course, thanks to research, we now know that the HIV prevention toolkit is slowly emerging. We now have more new HIV prevention tools than ever before. But even though this is the case, we know that globally, the progress that we have made towards reducing new HIV infections has rather been slow, as it can be evidenced from the UNAIDS latest data, which actually shows that in 2019 alone, new HIV infections were more than 3 times higher than the target that UNAIDS had set for 2020. Of course, we know that one of the reasons why there's been such a slow progress is because even though we have quite a number of tools available, access to these tools remain rather a challenge, of course, due to several factors, including social, financial, community structure, as well as structural factors. And there's actually a need to increase access and utilization of the existing tools that we have today, as well as we need to continue increasing the number of HIV prevention tools that are available in the HIV prevention toolbox. But of course, the good news is that we know that we now have new HIV prevention tools in the pipeline soon to be available on the market. We know that long-acting cabotegravir has actually shown that it is effective in preventing new HIV infections among different populations, including MSM, cisgender women, and transgender. The dapivirine, on the other hand, also received a possible EMA opinion following clinical trials that also demonstrated that the ring can actually prevent new HIV infections. The exciting news is that the manufacturers of both products will soon begin applying for licensure and regulatory approval in targeted countries. And soon conversation around financing, policy implications, how the system as well as the delivery mechanism will be underway. And it is important to make sure that as with those conversations are progressing, there's need to involve all the relevant stakeholders, including the targeted beneficiaries of these products. Of course, these new tools, HIV prevention tools, do offer quite a number of potential benefits, and one of them is that when you think about both products, dapivirine and long-acting cabotegravir, they're both long-acting products, which definitely means they would address some of the issues around adherence, which has been a challenge with some of the tools that we have available to date, especially Oloprep. And also, when you look at the Ling and the Kabele, when you think about their delivery mechanism, both products are quite familiar in such a way that we already have rings and injectable contraceptives that are currently in use. So once they're introduced on the market, they will be quite familiar as far as the delivery mechanism is concerned. Again, when you look at the HPT and OIT4 and OIT3 trials, Kabele also seemed to work much better than Truvada. Of course, we are not saying that Truvada doesn't work. We know Truvada work pretty much as well, but Kabele was rather even worked better in those clinical trials, which means it would definitely give us the impact that would be required as far as reducing new HIV infections is concerned. Of course, in the long run, we also know that using long-acting methods may be cost-effective, and it would even mean less clinic visits for clients that will be using these tools. But also, since both products can be used discreetly, it means that it actually takes away that pressure, of disclosing to your partner and that partner dependency, which has been a challenge, of course, with some of the tools that we have available to date. It also takes away that burden of taking a daily pill. And again, it also, the new tools definitely also increases the number of choices, HIV prevention tools that are available in the HIV prevention toolbox. And something that we've continued to learn from the contraceptive field is that when you increase the choices, the number of choices available, you definitely, it actually increases the number of people that are accessing the services. Of course, there are quite a number of issues that needs to be considered as far as delivering the access of these new tools is concerned. First, it's important that as we're thinking about delivering and rolling out these tools, we need to think about differentiating the delivery of these tools based on the needs of the different target groups or populations that will be targeted for these tools. And something that we have learned, of course, from the rollout of Oloprep is that it's important for us to avoid medicalization of these new tools. And we should, at any cost, try as much as possible to avoid delivering these new tools in the ART settings, rather, as this brings in a lot of stigma. And this is something that we have learned, of course, from the rollout of Oloprep. Again, it's also important as we're thinking about delivery also to go beyond the facility setting and where possible, try to consider, community delivery, and the goal should be bringing these tools closer to the people who need them and that no one is left behind. Again, as we are also drawing plans for rollout and as budgets are being drawn, it's important also to make sure that availability of these new tools should definitely match the demand that is there on the ground. Of course, successful rollout of these new HIV prevention tools will actually require a lot in terms of strengthening the district level health systems. Definitely there will be need for a multi-stakeholder approach. It's important that as plans, as we start planning for rollout, all stakeholders should be on the table, including civil society and communities in the targeted communities for these new tools. There's also need, of course, to strengthen the supply chain system at the district level as one way of ensuring that there's an uninterrupted supply and access of these new tools. Adequate infrastructure and human resources for health definitely will also be required, to ensure quality delivery of these tools and services. Again, a supportive policy environment will be required. And last but not least, there will also be need, to strengthen the M&D system at the district level as one way of ensuring that we are with this real-time access to data, and that will then inform programming and targeting as these new tools are being rolled out, but also it will actually help us to be able to appreciate the impact that these new tools will have as far as reducing HIV infections is concerned. So in conclusion, we know that yes, we've made some progress in reducing new HIV infections, but there's a lot of work that still needs to be done. We have tools and more tools. We know that we have more tools, HIV prevention tools available than before, and that we have new tools again, in the pipeline soon to be available on the market. But for us to be able to achieve the desired impact in terms of reducing new HIV infections, it's important for us to make sure that these tools are not just made available, but that they are also accessible, especially for the people that are in need of them. So it's important for us to make sure that there's an enabling policy environment, there's a strengthened in the health system at all levels, at national as well as at district level, that will then allow for effective as well as a successful rollout of these new tools. Thank you so much for listening.
It has been a very exciting and informative session. We have come to the end of the session. Let me thank all the panelists who contributed to today's session. Over the 5 years, the Blantyre Prevention Strategy will catalyze a district-level HIV prevention delivery system that is equipped to detect and target risk, generate demand, and effectively deliver prevention products and interventions to those most at risk. This system will be built through investments in key health systems, health system enablers such as governance and technical capacity, data availability and use, and the community engagement. Strengthening these health system enablers through the interventions we heard today will enable more effective local capability for programming along the HIV prevention cascade. And this will ensure the sustainability of the program. Through modeling, estimates, the formation of a prevention data pipeline, and improved surveillance through the IDSR HIV pilot, the health system in Blantyre will be improved to detect risk and respond rapidly to provide HIV prevention services and tools targeted those most at risk. Through improving the linkage to communities through grassroots human-centered design and investing in other sustainable demand generation strategies, prevention programs will be designed with communities at the center, made attractive to at-risk populations, and increasing further demand for services. These services will be further improved through quality improvement collaboratives. Ultimately, the health systems approach will bolster the success of existing partners while testing and iterating to create opportunities for greater district ownership and more economical, effective, and replicable long-term HIV response. This new approach to HIV prevention is needed for Malawi to reach prevention goals. The Blantyre Prevention Strategy aims to develop a replicable model for effective HIV prevention focused on embedding critical systems and capabilities into local government, civil society, and other partners. It is therefore hoped that as learnings emerge, they may be scaled up in other districts. We hypothesize that improved functioning of the HIV prevention cascade will result in an accelerated decline in HIV infections and long-term epidemic control in Blantyre, but also Malawi as a whole. I thank you all for the listening and wish you a blessed day. Bye.